presenter is going to be Dr. ANAND VINEKAR, who is a joint winner of P. Shiva Reddy Award. The topic is KID ROP.
At the outset, I'd like to thank AIOC and AIOS for this honor. It's such an honor and privilege to share the award with a legend and to present before my teachers from whom I've learned everything. I'm going to talk about the KIDROP program, which now runs in its 16th year. It was a telemedicine program. We have the distinction of doing free screening and free treatment for all babies born in government hospitals throughout the state of Karnataka. But it started small. This slide has not changed for the past 15 years. It's a model where we train technicians to go inside the rural ICUs, screen these babies using wide field imaging, upload these images on a telemedicine platform, which are read by a hub and spoke model of ROP specialists. This started off with the technology that you're seeing there, the very first iPhone, a very large red cam, and so on. What has changed is technology, the way we've used it, and that is the progress. It started off as 3 hospitals. Today we cover 144 NICUs. We've almost crossed 2.5 lakh babies, and close to 4,000 babies have been treated. This is the change in technology. We now use an Indian camera. We have trained now technicians not only to report, but also to integrate with artificial intelligence machines. The program started off first with a 2010 national guidelines, and there was a significant amount of confusion on which babies should be screened. India at that point did not have a national guidelines. The KIDROP model was recognized by Government of India's Ministry of External Affairs and Harvard Business School, which said that this is a reverse innovation model which can be used by the West. Subsequently, business schools have studied the model, Indian Institute of Management, Ahmedabad and Bangalore. And in 2009, this was the first time a healthcare app went onto the Apple phone, which was at that time the first touch phone. The business model had to be published first before we actually published the scientific model. And I remember my mentor, Dr. Dogra, telling me, unless you publish it, no one's going to believe it. So it took us 7 years of validation before which we decided that this is a public-private partnership. And the government took it from there onward. And this CAPAM award is an international public health award, which Government of India came semi-finalist as first runner-up. And then subsequently that year, we won the Public-Private Partnership of the Year in 2012. So that's about 11 years back. The work in KIDROP, because it has been outreach and multi-center, has shaped the guidelines, the national guidelines. What we had shown was how we can improve follow-up in rural care, how we can reduce the incidence from 80% to 30% just by monitoring and informing neonatologists how to maintain it better. We also showed that you don't have to wait for 3 to 4 weeks. You can do the first screening before discharge, and how to improve the follow-up even after these babies leave your rural center. This was finally the first publication that made it to an ophthalmic journal, an IGO. It now has more than 200 citations. But subsequently, the model has been tuned and retuned. In 2014, the American model tried to emulate ours. They have a 2-week turnaround time where the images go back. But we, because necessity is the mother of invention, we have to tell the mother when to come back, and our turnaround time is a few minutes, at best 15 to 20 minutes before she leaves the rural center. Paper after that has refined the models, which has finally made it to the RBSK national guidelines in 2015, a group constituted under the leadership of Professor Azad and Government of India. And then finally came the operational guidelines in 2018. India is the first country to allow wide field imaging as a proper screening methodology, and we are very proud of this. And this has subsequently been emulated by several of our neighboring countries and other Eastern European and Latin American countries as well. But we went one step further in terms of universal screening. If a picture could take ROP, why not something else? And that's when we found that so many other conditions can be picked up as well. This was the universal screening paper in 2012, 1,000 babies, which was mirrored by the neonatology circles in 2013. And then, and finally, in 2015, 2016, the government spoke about universal screening guidelines, which came under the RBSK guidelines of 2016 and 17. We were assessed. We opened ourselves to an open book kind of evaluation. The first one was by the UNDP. They came and visited us, traveled with us, looked at all our books, and this was then named as a good practice for middle-income countries. We were then evaluated by the Australian government under the CDC guidelines, and this I quote from their report. It says that if you go back to indirect ophthalmoscopy and you're not imaging, you might be opening the Pandora's box of medical legal litigation. So finally, okay, so it was a great model, but then how to expand? And the cost was the limitation. We then worked with local industry to come out with a Indian camera. By then, Government of India had floated the Make in India scheme. And under this, with help from IIT Madras, we came out with Forus, which is the Bangalore-based company. We came out with India's first wide-field imaging camera. Today, it has apparently more than 150 installations, 150 countries with an FDA and CE approval as well. We published it, comparing it with the RedCam, and subsequently Government of India awarded the company, IIT and us as partners, the Innovator of the Year in 2018. This is the newest model of the NEO. I have no financial interest, our institute has none, but we tested now the angiography module of the new wide field HD. This is in the NICU, it's good, it's got work in progress, it's not yet been published, but we're writing up the manuscript. And with the help of Dr. Bende, we looked at all other innovations that we can bring into the rural areas. Then finally they said, okay, now you have a low-cost camera. Can we train pediatricians or neonatologists or nurses to take these images? So that was the next plan. And we started working with Kerala government, Madhya Pradesh government, and our own government in Karnataka. A pilot project showed that nurses can be very well trained to do these imaging. And much before COVID, we had kind of got an online training platform. This platform came very useful during the pandemic, where a few days were spent in our center. The rest of the training happened with these technicians in the NICU itself. Two of us from India have represented the country in the ICROP3 guidelines, and this, for the first time, looked at our type of disease, that is the aggressive ROP. So no longer is it called now aggressive posterior ROP, and some of these images are contributed from the KIDROP image group, where we see disease that looks innocuous because the blood vessels seem to be going to the periphery, but they are very sinister, especially when you do an angiogram. Telemedicine becoming part of the Yanov textbook, probably I wouldn't have thought of when I was studying Yanov, but I'm so glad that they picked it up as one of those things. We've tried to look at research also, and all our research is funded by our own program. We've not got grants to do our research. And whether it was serendipitously picking up what we then called macular edema of prematurity, which has then been shown in other ethnic groups, or the first study to do OCT angiography in a baby and in a group of babies, where we found that they can be 6'9" or better, but they have angiographic or OCT angiographic changes that don't make them normal. And what long-term impact that will have is something we need to see. And of course, contrast. In these babies so tiny, undergoing ROP screening, we are now able to test contrast and then predict whether low contrast also means low vision at the end of 6 or 9 months. And finally, the most exciting work that we're doing in basic science at ANAND in Bangalore is the tear fluid. You've seen my colleagues present it in anterior segment, and we've done a small pilot. We've published the first paper in IOVS, and the prospective is also being written up. I never believed that babies who are just a few weeks old could even produce tears, but here it is 20 millimeters in height, and all of it is being analyzed for different annulates. And we are now able to predict, based on what we are picking up in the first screening, which baby will get the disease or not. And we think we'll be able to fine-tune it to decide whether they will require treatment or not. And that, as you can imagine, might be a paradigm shift. You might be able to tell the mother when to come back, if at all, if the risk is higher. And of course, we were not going to be left behind in the AI bandwagon. We started off by looking at poor quality images to see how we could enhance it, then started doing the slightly more deeper segmentation to look at plus and pre-plus. And finally, with independent work that has been done by a whole lot of biomedical engineers across the country, we have finally picked up some of these models and are in the process of integrating it with our telemedicine project. This, for example, is a standalone project done by a lady in Chennai who defended a PhD on this, and she just looked at these images, and her algorithm is able to pick up from a RedCam image or a Neo image whether it is stage 2 or stage 3. As more and more low-cost cameras come into the market, AI probably will be the way to triage this forward, and its sensitivity and its accuracies in the early 90s, it's good, but it's not amazing, and there's work to be done. This subsequently was awarded the Rangachari and the Innovator of the Year at our very own AIOS. Finally, we are trying to do whatever we can in terms of the advocacy, and under the guidance of all the mentors that you see here, we formed the Indian ROP Society, probably the first one of its kind in the world. We have a few peer review publications where we brought out saying this is going to be our short-term, mid-term, and our long-term aims and goals. And basically the aim is to bring the best level of care in the outreach for all our babies. And we've described the challenges. The biggest challenge came to us during the pandemic. And we were probably the first country and the first society to come out with guidelines. By end of March 2020, we had put it up on our website, of course, made a peer review publication years later, just a few 6 months back. But we were trying to tell the world, don't stop ROP screening during the pandemic. These are the things you can do to get around the problem. Even before social distancing and all those things came out from the national guidelines, we were talking about it in terms of an ROP perspective. This is me trying to treat a COVID positive baby. The date is important, I guess. It was the first week of April in 2020. We had no clue what we were dealing with. And finally, the ugly head of medico-legal litigation in ROP is something we've been trying to trace. This was a non-peer review publication, first in the VRSI, which then VRSI journal, and then we made it to APJO, where we look at the different cases that have gone against a pediatrician and an ophthalmologist and how we can best mitigate that risk. And there are some guidelines we've done, learning from the cases, learning from the judgments that have gone against these doctors. Yes, our work has been now accepted as at least the basic science work and all the publications in the top 2 scientists of the world. And the impact, I think the impact of any program is how much difference we can make to society. This we have mentored now teams from all these countries that you can see listed here. More importantly, what work are we doing in India? And these are the states that we have mentored with at the public-private partnership level and through the governments as well. And I think it's really important not to stop until all these babies are covered at the district and the taluk level. This is a publication we put out to say if the KIDROP module is emulated in 9 other states which have the biggest ROP burden, what kind of blindness can you prevent? And politicians understand numbers and fiscal numbers. So it's $108 million that we can prevent just by preventing blindness in babies who are 1 or 2 months of age. And because they have a lifespan of maybe 80 plus years. And as our life expectancy goes up, this is a formula used by the WHO. Number of babies prevented from going blind into the life expectancy into the per capita income. We have now crossed about 3,000 crores of blindness. Sounds like a great number, but there's so much more work to be done. I'd like to end by thanking all our collaborators, beginning with Government of India, all the other societies, universities, both in India and abroad. Thank you very much. Once again, thank you, AIOS, for giving me this award and allowing me to share it with a legend.